Actually, I have some great slides, but I decided not to use them right now because I was going to talk about how observational data might be useful in weighing risks and benefits, but I was asked to be a discussant, and the talks were so good that I thought I would make a few points instead. Now, Bert started off by talking about matching as a way to find the best way to manage this particular patient. And the idea goes back very far. Pierre Alexander Louis in the 1800s did this, and one of his great studies was looking at bloodletting in pulmonary disease. He was shocked to find that it wasn't as beneficial as he thought it was before he started the study by doing all this matching. And it has been the mainstay of work on the efficacy of treatment until the randomized trial came about. But as we've been saying repeatedly during these discussions, the main problem is always selection bias or confounding by indication. Why did the person take this treatment versus that treatment? And my mentor, David Beyer, wrote a paper on this topic when databases were becoming more widely used. And his paper in Biometrics in 1980 has the following concluding sentence. It has been argued that data banks can address a wider range of questions than randomized clinical trials can. The big question, however, is whether data banks can answer them. And the question about whether they can answer them has to do with this issue of, can we match on the right things that allow us to control for this confounding by indication? Dave Byers was working at the time on very nice registry data on thyroid cancer. And he had some people who got radiation, others who got surgery. And the people who got radiation did a lot worse, but he couldn't conclude that radiation was bad for you because he didn't know why they got the radiation, even though he had a good registry of all. So this is the recurring theme, confounding by indication. And now Dr. Tatanetti has given us a nice introduction to this topic, but and a very thoughtful assessment of how to use observational data to get an idea about adverse events. And the advantage, of course, is that you have a large data set, but you don't know exactly who's being reported, why they're being reported. He just touched on that. But he thought he had a way of controlling for confounding by indication. And one example that I heard was his example of aspirin. Aspirin was associated with increased risk of cardiovascular events rather than decreased because of confounding by indication. Why was the, well, two possibilities. Either the people getting aspirin were also getting something else. Maybe the person who was getting aspirin was also on a statin because he had atherosclerosis, and therefore the aspirin was designed to prevent, and so what we're seeing is confounding by indication. If I understood Dr. Tatanetti correctly, we can control for that by knowing what other drugs the person is taking and maybe certain other factors like age. And possibly that does a good job. And it's certainly the example of looking at an interaction that he studied was confirmed by an independent laboratory investigation. That's great when you can do that. But the question is, do we really believe that by looking at the other drugs that a person is taking and possibly by age or maybe a few other factors, we can control for confounding by indication? And that remains to be seen. I think he said we need more experience in this area, but it really requires experience to decide whether we can control for confounding by indication in this environment. Now, Mike gave a very nice talk, and I thought I agreed with everything he was saying about the need for highly discriminating and well-calibrated risk models. And I do agree with that for many purposes. But then I realized that Mike was comparing people who had gotten radiation and their long-term survival with people who had gotten surgery and their long-term survival. Now, those might be excellent, well-calibrated models for those sets of people. The people who got radiation, maybe we've got a very precise, accurate, highly discriminating model for them. And those who got surgery, maybe we have a very highly precise and discriminating model for them. And according to Mike, we should just look at those two and then decide whether to take surgery or radiation. But that totally misses the question of confounding by indication. I mean, and what I would do if I were a patient would look at the randomized data, if I could, to decide whether it was the radiation or whether it was the surgery that gave me the best long-term outcome. I don't care what an observational study shows about the long-term survival of those people who got it and those people who didn't. What I want to know is which one should I take? And for that, you have to control for confounding by indication. Thank you.
And now our final respondent before opening up for more general discussion is Peter Bach, a physician, epidemiologist, writer at Memorial Sloan Kettering, and recently arrived colleague.